Welcome to The Vascular Voice, a podcast devoted to demystifying your vascular health. We're going to be talking about things associated with PAD, also known as peripheral arterial disease. And these are the things that matter to patients who have or are at risk of developing PAD. I'm your host, Dr. Jeff Martinez. My co-host today is Micah Johnson.
Hello, hello.
I've known Micah for, I don't know how many years now.
Most of my adult life, yeah.
Micah is a registered vascular technician, or also known as an RVT. An RVT's role in the care of vascular patients is very important. RVTs perform non-invasive studies that are very important in the evaluation for PAD. Well, this is our second podcast this month, September, which is PAD Awareness Month. We've previously discussed that PAD is when you develop fatty plaque that develops in the arteries that causes the arteries to become blocked, which can lead to detrimental conditions in the tissues such as the feet, toes, muscles, beyond those blood vessels. We also discussed that PAD can lead to limitations in activity, infections such as gangrene, loss of the leg, and even death. So it's an important condition to recognize. Well, welcome, Micah. Why don't you start off by telling us how you got interested in becoming an RVT, or how did you get to be an RVT?
Thank you, Dr. Martinez, for that wonderful introduction, and thank you for hosting me on the Vascular Voice. It's a pleasure to be here. I've been a vascular tech for a little over 15 years, and what appealed to me was the hands-on approach that ultrasounds require. The exams that we perform are very technologist dependent, meaning one technologist can get different exam results than another technologist if they're less trained, less experienced. And that particular aspect of the job really attracted me. I've always been an individual who enjoys art and performing to the top of my capabilities. And vascular ultrasound allows me to express my artistic side and also help out a lot of people by providing high quality images that our physicians use to not only diagnose, but subsequently treat the patients. A poor exam can lead to a poor outcome. And a lot of people think of an exam as being unimportant or trivial, but these exams really do determine the outcome of the patient. And by providing you and your fabulous team with accurate ultrasounds, you can treat the patient to the furthest extent possible and in a timely manner, especially if we can identify the issues early on.
Oh, you're quite right, because we do depend on these studies to make a plan for the patient. Every patient has their own differences, their own nuances of disease. And because of the options that we have today, one nail just doesn't fix the problem. So having these studies really helps us develop a good plan for the patient to bring about the best possible results that we can. But I wanted to ask you specifically, what experience did you have that you said, I want to be an RVT?
I see. The good old backstory. I love that.
Yeah.
Well, when I was in high school, I graduated and I was looking at all forms of medical care. I looked at nursing, I looked at CT scans, MRI, X-ray, and what drew me to ultrasound was the complexity of the exams themselves and also the potential to help a lot of people. Again, the exams that we perform are very tech dependent, and a tech who knows what they're doing will provide you an excellent exam versus a tech who is not as experienced or confused. There are a lot of things that we can bring to the table to improve the care of the patients, and that's what attracted me the most, was the difference that we can make. With CT and MRI, very, very crucial diagnostic tools, but one technician can technically take an exam similar to another. If parameters are set to the exact same degree, one exam versus one technician could be exactly the same as another. With an ultrasound, I don't think that there's any technologist that could produce the same exact exam as another technologist. There's always going to be a touch of that particular tech, what order they go in, what level of disease they find, how they document that disease. And that level of speciality is what truly interested me in vascular ultrasound. A valuable vascular tech can make or break a physician's practice because the doctor doesn't see the pictures you don't take.
Right.
And he can only see good pictures if you take good pictures. If your imaging quality is substandard, then your outcome is going to be substandard. I always have been attracted to fields that reward you based on your excellence, and we always want to provide excellent imaging for our patients. The patients are the main reason we're here. They're the only reason we're here. And so we take every single exam, which is for the most part textbook, but every single person is individual and everyone is special. So you have to take that special delicate touch with every single patient. Otherwise, you may miss something crucial, and in turn, the doctor may miss something crucial.
For sure,
So
for sure.
every single patient is important. Every single patient is their own individual case, and I love that about our work. We help so many people. No one is a textbook patient. Everyone requires a unique approach to their care and their treatment. And I feel that with vascular ultrasound, especially working with your group, we accomplished that. So, job well done.
So then you were looking for a job in the medical field.
I was.
You picked becoming a vascular technologist. What kind of training is involved that gets you to that point where you can come on board and be that extra person in the physician office or outpatient center, wherever you're working?
Very true. Very true. Back in the day, you could do on the job training, and that's how a lot of techs learn. They converted from X-ray, sometimes CT, MRI. They have done away with that probably about 10 years ago or so. Now you are required to have at minimum an associate's degree. It's generally a 2-year program, and some programs are bachelor's degrees. You can get on the job training, but you have to be registered and qualified by another registered tech for you to be able to perform these types of studies. So generally it's a 2-year, 4-year program. On the job training still exists, but very rare.
Okay. So let's talk a little bit about what kind of testing we do. The patient comes to the office, they see the doctor says, yes, I think you may have PAD. Maybe they were sent by their primary care doctor. They were concerned about this. Maybe they have something more serious like a leg ulcer, or maybe they have gangrene, and we're trying to figure things out. So what kind of tests do you perform in the lower extremities to help the doctor or healthcare provider to determine whether there actually is PAD?
Of course. We provide generally 2 exams. One is a pulse volume recording, which is considered a physiological exam. This exam is used to check for functionality. It would be what you would consider a quantitative test. The quantitative exam is good because it allows you to assess the limb overall. It doesn't tell you specific data, but it does give you a very good broad picture. Is the circulation good or is it bad? The good advantages to this exam is you can evaluate the ankle, you can evaluate the foot, and you can evaluate the small vessels of the digits, which you really can't evaluate through typical duplex ultrasound. This particular ultrasound is performed with pressure cuffs that are applied upon the ankle, the foot, and also the digits. And this particular pressure cuff is capable of sensing the strongest artery underneath it. Now, it doesn't tell us which artery that is, but it does tell us, is the flow good, bad, or not so great. So that gives us a broad evaluation on what the blood flow looks like. Where we add into that is the duplex ultrasound.
Well, before we get to that, on this study, so you're using blood pressure cuffs.
That's correct.
So a patient is going to experience blood pressure cuffs. Do these cuffs all go up at the same time? Do they go up separately? How does that, just briefly kind of describe, if you're the patient laying there on the table getting this study, what can they expect to feel or encounter?
Very true. Whenever we do a pulse volume recording, the pressure has to inflate just above the venous pressures, which is generally around 50 or 60 millimeters of mercury. It does that to basically get rid of the extra noise that you would get back if the venous flow were still active. So it seems like it's going to be like a normal blood pressure, except probably about a third of the pressure you would generally experience.
So it's going to be a gentle squeeze.
A gentle squeeze. That's right. I like that. I am a gentleman after all.
And so these cuffs, you do the toes separate, correct?
Yes. When you apply the cuffs, depending upon your machine, you can generally do right and left legs at the same time. This is nice because you can see one leg versus the other, if one's grossly abnormal versus one that's very, very normal. Not all machines can do that. Sometimes you have to do each extremity one at a time, but we generally do the ankle first, then we do the metatarsal, and then we do the digits. We start at near the top, and then we work our way down. Generally, the pathology is going to start up higher and then work its way down. You generally see the worst stuff at the very, very bottom. All of those blockages up higher ultimately affect the foot the most. And so we're really, really interested in the foot and the digits, especially because this is the best way, one of the most cost-effective ways, and also no risk of radiation, no needles, no knives, and we can fully assess the blood flow to a person's foot. A lot of times the ulcers are on the foot. They're
Right.
at the midfoot, they're on the digit, and this is one of the better ways that not only can we look at it before procedure, but then we can also follow it after the procedure to make sure that our values are improving and that we can promote good healing. We all know that our toe brachial indexes also give us a good inclination.
Well, we can talk a little bit about that.
I'm getting ahead of
I
myself.
think a little bit you are. But so for this test, basically, as the disease progresses down the leg, if they have disease at multiple levels, in other words, we're going to see it compounded in this test further down the foot.
That is correct.
So we're really using this study to give us an idea that there is in fact PAD. We can't exactly tell what level it's at with this study, but we have a pretty good idea about where it is. And so this is also a really good test to identify whether someone has PAD or not. It's pretty simple. And for somebody that we're not really sure what's going on, maybe they have leg pain, but we're not sure where the pain's coming from, this can really tell us, hey, this looks like PAD.
Yes, it can. And the great part about this test is it only takes 10 to 15 minutes. It does not hurt, it's non-invasive, and there's no risk to the patient at all.
And so now let's talk about what you were alluding to there, the ABI and the TBI. So when Micah's performing these studies, there's a couple of indices where we're looking at the ratio of the blood pressure from the arms to the lower leg or even into the toes. And that also gives us another indication of whether there is disease or not. And we can talk a little bit also when those tests aren't very good. One of the important things is that frequently we're required by the insurance companies to have these on record to support our belief that there is PAD or not. So let's talk a little bit about the ABI. So where you put your cuffs and what we're measuring.
Wonderful. An ABI is very straightforward. I like its name too because you can't mess it up. ABI stands for ankle brachial index, in that order. So basically what we do is we obtain blood pressures similar to the blood pressure that you would obtain at the brachial, at the arm, and we compare the pressures in the legs to the pressures in the arms. Now there's a few conditions that you want to do to have an accurate ankle brachial index. One thing is the patient needs to be essentially completely flat on their back, supine. Anytime a patient is elevated, the actual physical weight of the blood, we call it hydrostatic pressure, causes the pressure to subsequently increase, and that will completely throw off your ratio. A lot of people don't realize this, but your circulatory system is indeed a system. If the pressure in your arm is 100 or 120, then the pressure in your legs subsequently should be 100 or 120 or higher. That's the way your body is made to operate. Anytime there's less blood circulating, then it takes less pressure from the cuff to occlude the blood vessel. Peripheral vascular disease in the arm is fairly common, but it's much, much rare compared to vascular disease in the legs. So the arms are generally a very reliable source of blood pressure compared to your legs. By taking the pressure and then dividing it by the arm pressure, we get what we call an ABI, an ankle brachial index. Anything generally above zero point 0.9 is considered normal. However, there are caveats to that, as you already know.
Yes, so we have a very high diabetic population in this community, and diabetes can lead to calcification of the blood vessels, which makes your, just like it sounds, hard like a rock or like a bone.
Yes.
And that keeps your blood pressure cuffs from really collapsing the blood vessel to get an accurate number. What happens then?
That's a very, very good question. The calcification process generally affects the tibials more so than any other vessel.
And those are the blood vessels below the knee.
That is correct. And those are very, very important because they're very small as well. And a little bit of calcium can go a long, long way. When the blood vessels are so hardened, you're going to get a falsely elevated pressure, and it makes sense.
Right. And those blood vessels are the ones that we're using to measure that ankle brachial index. So if we can't get that compressed, then that's going to give us a false reading, which is generally
correct.
A high pressure. Right?
Correct. In those instances, sometimes the pressure is so hard you can't compress it at all. And sometimes they're falsely elevated. It will still compress, but it compresses in a range that is not consistent with the waveform that we obtain when we get the waveforms at the ankle and the foot and the digit. Generally, when our waveforms conflict with our pressures, that is a very, very good inclination that our pressures are falsely elevated. And unfortunately, in our diabetic community, this happens a lot, a lot of patients.
It does a lot.
I'd say probably 75%, 60%?
60, I'd say a good 60 for sure.
Yeah.
So that brings us to the TBI, when you have these calcified blood vessels that can confound the results of that ABI. So if you can kind of explain how we do that again, it's using a blood pressure in the arm, and now we're using the blood pressure in the toe as well to come up with an index. And if you can just kind of explain how that works and why does it work?
Happy to do it. The digits are taking a little bit differently than the pressure cuffs that we do at the ankle and the foot. And it is because of the small size, the very, very small size of the arteries in the digit. Because of this, we use a small sensor. It's about the size of your finger, and it has two infrared sensors. One infrared sensor goes into the tissue, and the other one picks up the signal once it bounces back off the arterial. Now, the way it works is essentially it detects hemoglobin. More hemoglobin you have present in your blood, the more the signal reflects and the stronger waveform that we get corresponding. The limitations to toe brachial indexes are the physical size of the toe. Sometimes the digit's just really, really big, and if the toe cuff doesn't fit just right, then sometimes the pressure will be falsely elevated. If the toe is too big, then the pressure may be falsely low. It could be, we call that cuff artifact. But most of the time, toe pressures are considered reliable in the medical community. It is possible that they can be altered erroneously. Infrared picks up movement. It picks up any kind of movement at all. And in some patients that cannot stay still, the pressures may not be reliable. But in the medical community, the toe brachial index is generally considered very, very reliable. And we do apply a small cuff with a little bit of pressure. Basically, the waveform is present when the vessel is flowing. We inflate the cuff, the waveform goes away, and then the waveform slowly comes back as the cuff is deflated. So it's a very reliable test, but still not perfect.
And then what do we consider normal? Do we have normal pressures or a normal index or both?
Anything 0.7 and above, essentially 70% of your brachial, would be considered normal. There's different criteria for abnormal, so I won't get into that, but everyone generally considers 0.7 and above is normal.
And I would just say that these are tools that we use. They can be wrong. We have to look at them all in context together, along with the evaluation of the patient and their physical examination, to really determine whether we think all the pieces of the picture add up and make that whole.
Absolutely right. And I'm glad you brought that up, because consistent waveforms always will trump the pressures. The waveforms, you can't miss that up. The cuff goes on the digit, or the cuff goes on the ankle, the foot, and then the toes. If that's a reliable and the pressures are not, the waveforms are the way to go.
Good point. Good point. So let's talk about the second type of study that we really ask you guys to do a lot, which is arterial duplex ultrasound. Um, so ultrasound, it's the same kind of thing. Many people have experience with seeing babies for the first time, maybe having their gallbladder with an ultrasound. It's the same type of technology, but we're looking at the blood vessels.
That's right.
So tell me what you do with that.
Oh, that's my art projects. I love that. Yes. So whenever we're scanning, we utilize a transducer. The transducer has a crystal in it that can vibrate to very, very high frequencies, hence ultrasound. The sound waves are distributed into the tissue and they bounce off pretty much any and everything in the tissue. And depending upon the makeup of the piece of anatomy that it hits, it creates an image based on essentially the stiffness of the vessel. Because we're looking at blood vessels and calcification, they show up quite well on ultrasound, and with Doppler, we can physically see the blood moving in real time through non-invasive testing. So we can actually evaluate the blood flow as it's moving and see where it's narrow, we can see where it's open, we can see where there's an aneurysm or a tear in the artery. We can evaluate quite a bit with ultrasound without causing any significant pain. There's no needles, there's no knives, there's no radiation. It's a very thorough, easy test with zero risk to the patient.
So unlike those PVRs that give us a general idea, now we're really able to hone in on what's causing the problem, where the problem is. And you scan from.
We start in the pelvis because generally your blood vessels, if you're going to have an issue, can start all the way up high in the pelvic area and affect as far as your great toe. We don't know, so we search the entire extremity starting from the very top and we evaluate the flow. Now, flow in your blood vessels is very similar to flow in a river or in any plumbing system. If you start at a position and the flow is abnormal, then that means that you probably have another problem further upstream. In that particular circumstance, the technologist should be aware that there may be something that needs to be further investigated. Because again, the doctor only sees the pictures we take. If we don't take the picture, the doctor cannot properly diagnose the patient, and we may not be able to treat the patient accordingly. Sometimes the blockages can start in the abdomen, and these blockages generally don't hurt you where the blockage is located. It'll affect everything below that point, but the blockage can be in the abdomen, it can be in the iliacs, it could be in the abdominal aorta. So traditionally we start at the common femoral. The common femoral.
Quick, before we get into that part, just for some of our audience that may not really know about the blood vessels. So you have one main blood vessel that comes out of the heart that goes to the legs, and that is your abdominal aorta that Micah was mentioning there. That splits as it goes into the legs, into the iliac arteries. That occurs in the pelvis area. And then that blood vessel splits to give some of the blood vessels into the pelvic area. And then the second blood vessel, the external iliac artery, goes towards the legs. That then becomes a common femoral artery, generally at the groin crease. Then that blood vessel again splits into a muscular artery and one that runs off down the legs, all the way down behind the knees. And then below the knee, it splits into three blood vessels going down to the foot. You have one main blood vessel going on the top of the foot. Then you have the second blood vessel running along the back side of the foot, on the inside of the ankle, and to the bottom of the foot. And then you have the third blood vessel that I kind of call the spare tire, runs to the ankle and is important when you have problems or disease in one of the main blood vessels to pick up that slack and add some blood flow. So you'll start scanning in the abdomen, pelvis, or at least in the extremity. And if you notice that the flow is abnormal, then you'll scan up higher. But then what happens when you start scanning down the leg?
So when we start scanning, the imaging that we're providing is considered in this instance qualitative. It's all about what is that particular segment doing? What is the main vessel doing? You'll have miscellaneous collaterals going here and there, but the doctor wants to know what does the main blood vessels look like? And so we evaluate those in two different views. One is called the transverse view, and one is called the sagittal view. The sagittal view is used, I would say, 90% of the time for your diagnostic imaging. So we'll focus on that. When you have a sagittal view, you see the artery displayed in a long axis, basically as if you were to cut it in the middle and you could just basically see the inside of it. This allows us to see.
So you're splitting the blood vessel lengthwise.
That's correct. And it's basically looks like a very long tube, a long black tube.
Right.
And because of the properties of blood, it shows up as black on the ultrasound. And because of the properties of calcification, it shows up as bright white. So we can see the bright white deposits on the films that we're viewing, and we can actually measure how the blood is moving in that particular area. The reason why we measure the velocity of the blood is because calcification, when you're viewing it from one person to another, is all relative. I could think it's 50, 60%. You may think it's 70%. There's always going to be that area of relativity based on the person who's observing it. So we've developed a velocity criteria in the medical community, and that is how we determine the degree of blockage. And the velocity criteria is very simple when you think about it. The example we like to always use is a water hose and a nozzle. A water hose that's completely open is nice and smooth, and there's no restriction in there. It can just flow, nice, smooth, laminar flow. Now, if you were to put a nozzle on a water hose, you didn't change the hose itself, you just created a smaller opening. So that smaller opening now has all that pressure that's built out of it, and that is what a nozzle does. It reduces the opening, and now you have a jet.
And I like to use the finger over the water hose, because just like the stenosis can vary, and so
I like that. Yeah.
Your pressure varies. So, or the velocity, the speed.
Yes.
So the higher the speed, the tighter the blockage, right?
Agreed. And most people don't seem to, that seems counterintuitive.
Mm-hmm.
Tighter blockage, higher velocity. How does that make sense? And you're correct. Because of all that pressure, all that buildup back there, it basically goes through that blockage like a little demon howling. And that's where those increased velocities occur. And those increased velocities correlate to a certain degree of stenosis. We've all have an established criteria, and the criteria will differ from establishment to establishment or practice to practice. But the velocity criteria is generally the golden standard to determine level of blockage and also provide a level of I don't know how to say it. We can reproduce those results from one exam to another. And when the blockage is cleared out, the velocity subsequently will decrease, and we can see an improvement.
Exactly. So you've explained a little bit about the studies that we do, and I think you can get an appreciation for as simple as they may seem when you actually have them done. There's a lot of complexity that goes into determining if the study's done appropriately, determining what degree of stenosis, and how that correlates to a patient's symptoms. But I wanted to go a little bit more and talk about what kind of things, how do we know? So what kind of things do you do to check yourself and your ultrasound results compared to what the patient may really have? Because like you said, this is a highly tech dependent procedure, and every tech may do things a little bit differently, but ultimately we want to know what's really going on so that it helps the patient and we can make the best decisions for our patients. So what do you kind of do, I guess, in sort of a quality assurance fashion?
I'm glad you brought that up, and it's a very important issue. Any job that's worth doing is worth doing right. And the best way to know if your exams are accurate is with feedback, whether it be positive or negative. We provide ultrasound correlations that document what the testing was prior to intervention and then post. And our partners, our interventional partners, are happy to provide this additional information to make sure that our ultrasounds stay on par and that we provide accurate results. It's not always 100%, but we would like to be in the upper 80s, 90s. We score every single correlation, every single procedure on every single patient. It's really the only way to provide a blanket quality assurance program. If you only select a few patients here or there, well, you're not really getting the full picture. we take it to the next level and we provide correlations on every single patient. It's really the only way to guarantee the accuracy of the ultrasounds that I'm aware of.
And I think, one of the best things about working with RVT or an ultrasound technician is that we can have those services provided in the office, and we're able to work closely together so that if there's some nuance on the patient, we're able to exchange that information together or look at things together, hand in hand with the patient present in the room, so that we can figure out maybe what's confounding the study or maybe what's true. I mean, there's times where you or one of your other technicians have found things that were totally not expected. We've found cysts in the ovaries, we found cysts behind the knees, and sometimes those things have an impact on the blood vessels by causing pressure. So it's good to know those kinds of things. I think that the correlation you talk about, a lot of times you get feedback from us with when we actually do an angiogram where we've injected dye into the blood vessels, which is really considered the gold standard for looking at the blood vessels. And then we're able to go back and look at those studies and see, did we miss something, or, oh, maybe because of this is why this looked this way. And it just helps us understand. So this whole quality thing is an evolving practice that's happening continuously.
Yes, it is. And every tech needs that kind of feedback to grow and become experienced, because if you don't know, you can't get better. So you're absolutely right about that. And even when you miss certain areas, doesn't mean that we missed the mark.
Right.
We always want to know what we got right, what we got wrong, and continuously improve. And that is our goal. And I feel that we've done that. And I also love that you make yourself available. The fact that we're here on site to provide the testing, there's some times where we got to call you in the room because there's certain things where you got to see this. And the fact that we're here and that we can work together, I really think that this is the best atmosphere for the patients to be cared for.
So one last thing I want to talk about, and that everybody loves to talk about, and that's health insurance. Yeah, once again,
let that guy in.
We're oftentimes strangled by what insurances require. And many of you know, most of the time as a specialist, we've got to get authorizations for you to even walk through the door to be covered. But you also need to be aware that the ultrasounds also need authorizations. And so we're experiencing more and more difficulty, it seems, in getting some of these authorizations. What about for the testing that you do?
We've faced our fair struggles as well, for sure on that. And unfortunately, it's just part of the society that we're in. These ultrasounds are done with very specialized equipment, and unfortunately, it's expensive equipment. The techs are also, specialists as well. And it really is something that most patients can't afford on their own. It's not really expensive, but at the same time, most average people just can't drop a couple $100s for just an exam to see if there's a problem. And so we do utilize the insurances because that's what the insurance plans are there for. However, we are still held by their standards of operations. We do have to ask permission to make sure that the patients don't receive a bill that they don't need. They have insurance for a reason, and that's why we have to go through those proper channels. Unfortunately, it's not always convenient for the patient. It's sometimes a hassle and a headache, and it's a hassle and a headache for us as well. But at the same time, it does cover the cost for the patient and it gives them the care that they need. So if we have to jump through hoops, we'll jump through the hoops. Our patients are worth it. We just, it's one of those fights that we just have to keep fighting, and we hope our patients understand that a lot of times our hands can be tied. You have to wait for the insurances to respond to you. You may have an agent who's had a rough weekend. I've seen all sorts of excuses for why we can't get an authorization. It's a double-edged sword. I hate to say it, but insurance is necessary to get things done. In your procedures, I mean, the catheters, the equipment, all of that has to take into consideration, and most patients simply can't afford it. So insurance, it's not the funnest thing to deal with, but A necessary evil, I suppose.
It is, and it's a little ironic that we're seeing increasingly that insurance companies are requiring Micah studies for us to even get approval to treat the patient afterwards, and to think that we have the difficulty in getting those studies approved when the insurance requires it is probably discussion for a whole nother day.
Yeah, agreed. But you know what? The fight's worth it. We're saving limbs, saving lives. I can fight the insurance. I know you can too, right?
We do every day. So.
Amen.
That's all for today. In the future episodes, we'll talk more about different aspects of vascular health that will interest all of those who care about PAD. I'd like to end this episode with a verse out of Psalms 147:3. He heals the brokenhearted and binds up their wounds. Have a good day.